My second topic is about arterial stiffness. This slide shows the concept of arterial stiffness. You can see here this normal compliant artery. They have abundant elastic fibers, so they can have buffering effect for the pulsatile energy from the left ventricle. However, in the stiffened artery, there is arterial wall is rigid. There is less elastic fibers, so you can see here the pulsatile energy directly go to the target organs, and more target organ damage can be expected in the stiffened artery. In arterial stiffness, the pulse wave velocity significantly increases, so early return from the peripheral bifurcation and causing the systolic pressure augmentation and diastolic pressure decreased. This results in increased pulse pressure. So systolic BP elevation is associated with left ventricular hypertrophy, and the diastolic pressure decrease is associated with undercoronary perfusions. Also, arterial stiffness usually accompanied by other cardiovascular risk factors, including age, high blood pressure, and diabetes, and so on. And chronic inflammation, endothelial cell dysfunction, also other combined risk factors for atherosclerosis progression. So many studies showed the prognostic value of arterial stiffness. In this study, baseline higher level of carotid femoral pulse velocity was significantly associated with higher incidence of cardiovascular event in Framingham Heart Study. This is presented for the classical case of the two patients with the similar age but the same sexes. In the A, he has only one risk factor, dyslipidemia. He complained chest pain, and we performed the coronary angiography. There was no significant stenosis. You can see a pulse wave form. The augmentation index is only 15%. However, in the B, near the same age male, but he had multiple cardiovascular risk factors: hypertension, diabetes, smoking, and prior history of stroke. Also, invasive coronary angiography showed that triple vessel disease. His aortic waveforms show that very higher level of augmentation index. There are several types of measure of arterial stiffness: pulse velocity measurement, imaging study, and invasive hemodynamic measurement. Among these methods, pulse velocity is the most widely used method to assess arterial stiffness in clinical and research field. There are two types of pulse velocity. The first one is classical carotid femoral pulse velocity. Physiologically, this carotid femoral pulse velocity includes only elastic arteries, so it's more conceptual, more reliable indicator of arterial stiffness. However, to measure carotid femoral pulse velocity is some difficult because the finding proper position of femoral and carotid artery is some difficult and needs some skills. Also, the patients usually complain about the palpation of neck and femoral area artery. However, in Japan, they developed a brachial ankle pulse velocity. This method is more simple, easy, because just wrapping blood pressure cuff the upper arm and the ankle area. So also data showed that the brachial ankle posterior velocity is well correlated with the investigatively measured arterial stiffness. So the in the point of view cost effectiveness, the brachial ankle posterior velocity is more simple, easier. Also, data show there is reliability. So in the method screening method, I think that brachial ankle posterior velocity is more appropriate compared to the carotid femoral posterior velocity. In Japan, many data in various populations, the prognostic value of brachial ankle posterior velocity has been demonstrated. Our group also performed several studies to show the prognostic value of brachial ankle posterior velocity. We stratified the patient into 3 groups according to their risk. The low risk, only risk factor 1, and moderate risk group, risk factor 2 or more, and high risk group in patient with documented cardiovascular disease. You can see here brachial ankle posterior velocity showed significant in the prediction of cardiovascular events. So in the diabetic patients and menopausal women, also the very similar result. This posterior velocity showed significant prognostic value. More than 10,000, we also investigate the prognostic value of posterior velocity according to the clinical situation. The men and women, young age or old age, and obese, non-obese, the use of statin and hypertension, EGFR. All these groups, the significant prognostic value of posterior velocity we could observe. Recently, expert consensus make cutoff value of brachial ankle posterior velocity. You can see here the low risk finding less than 15 meter per sec, and borderline between 14 and 18. High risk findings more than 18 meter per sec. We know that carotid femoral posterior velocity more than 10 meter per sec indicator of high risk finding. Another important thing is that we can elevate the prognostic value if we combine information of 2 risk assessing modalities. You can see here posterior velocity with the CRP information. We can improve the risk stratification. Very similar finding was also obtained if we used posterior velocity information and ACC AHA risk scoring system. In coronary CT angiography, the obstructive CAD in patient with obstructive CAD in coronary CT angiography and with higher posterior velocity showed that worst cardiovascular prognosis. However, if the patients have non-obstructive CAD in coronary CT angiography with the lower level of posterior velocity, show there is only few patients suffer cardiovascular events. Serial measurement of posterior velocity also valuable. You can see here at baseline and at 1 month the serial change of brachial ankle posterior velocity. If this posterior velocity increase, the patient prognosis is worse compared to the patient with the decreased brachial ankle posterior velocity in patients underwent PCI. Recently, the research on the Hack-Lyoung pulse velocity significantly and continuously increased. 2018, in the ESC hypertension guideline, they recommend the use of only carotid femoral pulse velocity in the assessment of hypertension-mediated cardiac organ damage. However, recently updated hypertension guideline, they recommend the use of both carotid femoral pulse velocity and brachial ankle pulse velocity. We should think about the reliability of brachial ankle pulse velocity because this pulse velocity usually depends on the blood flow to the lower extremities. So we should check the ABI. The main strength of brachial ankle pulse velocity is we can obtain information simultaneously about the ABI, ankle brachial index, is an important indicator of atherosclerosis. However, if the patient have ABI level less than 1.9, suggesting a peripheral arterial disease, and the reliability of brachial pulse velocity value significantly decreased. So we should exclude this patient when we analyze the result of brachial pulse velocity. Also, major confounding factor for pulse velocity is age and blood pressure. So using the multivariable analysis, we should adjust this confounding effect of age and blood pressure. This is my take-home message. Arterial stiffness is an important marker for cardiovascular risk assessment. Brachial ankle pulse velocity is simple and very practical, so it is particularly useful for mass screening. Recently, it has been widely applied in Asian patients with many abundant clinical evidence. Recent expert ASEAN consensus was developed, and the high-risk finding is more than 18 meters per sec of brachial ankle pulse velocity. So another important finding is we can use this pulse velocity itself as a prognosis marker, as well as when we combine with this pulse velocity with other risk factors or imaging result, we can improve the risk stratification power. Lastly, ABI information is important. So we should exclude patients with low ABI, and also using the multivariable analysis, we should adjust the confounding effect of blood pressure and age. Thank you very much.